Good morning, everyone, and welcome to the WellMed Charitable Foundation's Caregiver Teleconnection session. Today, we have Alzheimer's disease and behavioral disturbances by Dr. Nestor Praderio, who is a geropsychiatrist. And we are so happy to have him with us because he's had so much experience in dealing with people, and he knows so acutely the things that caregivers are going through. And with that, Dr. Praderio, why don't you tell people a little bit about your background?
Well, good morning. Thank you, Evelyn. Good morning, everybody. I hope we fix what was going on with notification. And by the way, I think we always can talk to Minerva. That she is our right hands on this. I am Argentinian. I graduated as a physician in Argentina and worked for years as a general surgeon. And then I came to USA and I flipped in my decision of life and I started doing psychiatry at Yale University on the East Coast. And then I did a fellowship and then with a degree of a geriatric psychiatrist dedicated to the treatment of individuals that are 60 and older, specifically issues of dementia, depression of elders. And in 1994, I arrived to Corpus Christi, escaping from the winters of Connecticut, and happy here by the water. Next year, I'm going to celebrate my 30 years here. Happy to be with you here today. I am slowly transitioning to a retirement. I am a very ambivalent person. I am going to retire, and then the following day I come over here at 8 o'clock and I work 12 hours. But anyway, why I pick this subject? Because if dementia per se to caregiver will be a disease, this is just lack of memory, we will have a lot of less difficulties as a caregiver in dealing during the process of this devastating disease. What really marked the difference when an individual gets diagnosis with the disease, what really marked the difference is the type of behavioral disturbance that occur during the length of time and how difficult they are. Therefore, we will go briefly today kind of over this working agenda. We will define dementia. We will talk a little about the diagnosis. I will briefly show you type of dementia, and then we will get into the most important part. These are the behavioral disturbance. When we talk about dementia, it's a cognitive disorder of the brain that includes memory impairment, at least with aphasia, difficulties talking that we call the word finding difficulties. The person is talking to you and suddenly don't find the appropriate word and they get stuck on the process. They have apraxia, and apraxia is to have difficulty with a small neurological movement. We cannot whine or watch. We cannot click or pen. We have apraxic movement in a nausea, disturbance, and executive function. This occur in this deteriorate. Well, therefore, we understand that dementia is a deterioration of the mental function. is more severe than to say, well, my dad and my mom are getting old and are having some difficulties. No, we don't confuse that. Impact in your daily activities, in your social relationship, in your level of function. And remember, since we diagnosis is steadily progressive, is going stage by stage, getting worse. What is memory? It's the ability to store and to retrieve information. We can be more philosophical and talk about memory. We can be more romantic and have those that never abandon us. But there is a sensory memory represented by each one of the senses. There is a short-term memory. This is the one that gets impacted by Alzheimer's disease. And there is a long-term memory. And here we have approximately what are the incidents and what is the projection, how Alzheimer's disease will increase dramatically in USA. We have in year 2020, this will be around here, we have approximately an increment of the cases of Alzheimer of 7.7 million. And at the present time, we are approximating to the 6 million, but we have a projection that in 2050, we will have 13.2 million of individuals with the disease. Here, a little of I want to show to you what are different types of dementia. Remember, the most important dementia in the United States, 65% of individuals have Alzheimer's disease. 65% of the dementias are Alzheimer's disease. And then we go around with others. The following one will be vascular dementia. They sometimes cohabitate with Alzheimer's disease. These are 5% pure vascular dementias. They are not mixed with Alzheimer's disease. And then we have frontotemporal dementia, about 8%, Lewy body dementias, about 7%, and Alzheimer's disease mixed with Lewy body dementia. This is something that we are seeing more often, about 5%. But remember, main dementia, the highest percent in the United States is Alzheimer's disease. And how this disorder, how the dementia is affecting us. What are those symptoms? The memory is affecting everyday living. It's interfering with performing familiar tasks. We have difficulties naming regular objects that we use in a daily basis. We start getting lost in familiar places. Sometimes we get partially disoriented, then we recapacitate and say, oh, I remember now where I am. Decreased judgment. Sometimes this is marked by inappropriateness in what we say. The decrease of judgment and with the abstraction of thinking occur in executive function. Therefore, some of the parameters that we learn in life and how to behave in society, how to dress, how to present, are all distorted. Therefore, you have individuals with a disease that suddenly came out with comments these are not appropriate for the circumstance. There are change in mood and in personality. In general, they become more anxious and at the same time, partially depressed. The disease progressed through the years. And at the beginning of the disease, we have the initial cognitive symptoms. And those cognitive symptoms are some repetition because short-term memory is disturbed, and some act that we change in our habit and get more confusion. And the years go because the mark of the years are in here, look at. And by the third years, we start having more difficulties in having independence. We get more confused with what happened with the telephone. We type, and sometimes we will be missing part of what we want to say. We specifically have some difficulties at home with microwave oven. We calculating the time for the oven or for any other instrument on the kitchen. We have some difficulties with mechanism and functions. The man has been shaving with electrical razors or with battery operators, and suddenly they get confused and they cannot make them to work. About the center of the disease and year is where behavioral problems occur. And behavioral problems occur and start peaking in here. Therefore, is the higher point in which one we are going to have behavioral disturbance. And if you ask me, is this the point that we have more difficulties in caregiving? I would say yes, no doubt. And besides, this is the point when the majority of individuals under care end up in supervised environment. This is the point where people go to assisted living unit and to nursing home because the management at home is being more difficult. You can see and hear that you can go to a nursing home on the third or fourth year, but in general, here is the core when placement takes place. And some of the patients live up to 10 years in diagnosis. I have patients that has been living 12 or 14 years since diagnosis. But this is a variable on the year. But I want you noticing that this is the decline of the disease. And you know from beginning to end, and here occur most of the placement in nursing home. Some of the symptoms that we are going to see today, and we talk about the disturbance, the behavioral disturbance. Psychotic symptoms are characteristic of individuals having no contact with reality. There are some persecutory type of ideation reflected in becoming suspicious, inventing accusation, in accusing people of having malicious intent. Evelyn is not helping me today with this presentation. She just came to listen in, to stall the content of the presentation, to sell later on the content of the presentation and to really erase my name or hurt maliciously my name. And that's sometimes concrete. And it's not difficult because you hear this and you say, oh, it's so horrible, I will let it go. But sometimes it's extremely over-elaborated, and to the point that they make telephone call, that they call the IRS, that they call the police, that they call other corporations or associations, just making accusation of a caregiver, or my daughter, or my son, or my neighbor. And it's important because when you listen in the content of this persecutory ideation, end up becoming the delusion that we need to treat, because if we don't treat, become extremely dangerous. The hallucinations, this is a process that is associated with the sense that we have. We may have auditory hallucination, and we may have visual hallucination. Some sensory experience, not corroborated all the time. In general, in Alzheimer's disease, appear some visual hallucinations. They see individuals that are not there. They exacerbate during the evening hour. They get worse during the nighttime. And we always attempt to know, we caregivers, if they engage in conversation with the visual hallucination. Because if they talk back to the hallucination, we are having auditory hallucinations too. And it's important because if auditory hallucinations appear on the picture, we need to be careful that those auditory hallucinations won't be commanding. Remember, commanding hallucinations are those who tell individuals what to do. Take a knife, kill the dog, jump out, escape from your house. There are different auditory commanding hallucinations that I hear on the transcourse of my practice. What is apathy? Have a neurological prefrontal location, decrease the awareness of internal and external stimulation. Therefore, apathy disconnects you from your own feelings. At the same time, they disconnect you from the surrounding of you and leave you floating with a sense of distancing from everything. The sometimes is interpreted by caregiver, specifically by professionals in assisted living unit in a nursing home, as a good behavior. Good behavior means you don't say anything. You are sitting in a wheelchair, disconnecting from everyone, blunted. And this is a good behavior. It's much better to say you kick, scream, and talk delusions and hallucination. This symptom and the severity correlate with dementia severity. In the present, when you medicate the patient of extrapyramidal symptoms, side effect, predict the outcome, showing that the outcome is going to be worse. What is agitation? We have one that says psychomotor. That means we need to move. And the most common one that we have in dementia is wandering, walking, walking, walking. And it's non-directional, it's pacing and pacing. I bet sometime is connected with an increased verbal output. That means pacing and talking, interfering, intruding into other space. And then we have type of wandering individual. My team, when we go and work in a long term, the first thing that we say, well, what type of wandering is the person? Is the wandering, is the wanderer who walk the complete nursing home up and down and never try a door to escape? Is the wanderer who is exit looking and go through the exit and trying to leave? Is the wandering the one who cohort others? There are wanderers on the nursing home who have a little train behind or 3 more wanderers, and they walk and walk and walk, and they go all together without being friends, without talking. It's just a psychomotor agitation that they continue moving around. This agitation doesn't have a relationship with the level of cognitive impairment. If you are better or worse, there is no relationship. But inverse relationship with agitation is early age of the dementia. If you are demented at 60 or 62, you have more possibility to become agitated on the process and caring for. Therefore, we need to take it into consideration. Irritable affect occur at the very beginning when they are depressed. They sense that something is not right with them, but they cannot explain it. Occur later on, specifically when they are more agitated and aggressive. But this is a manifestation that correlates very well with cognitive impairment. The worse the individuals decline on the scale through the stages, the more irritable and uncontrollable they become. And in general, this irritable affect is like a light that illuminates and impact the rate of institutionalization. Irritable affect and agitation are the both who almost push the family into intervening with an institutionalization. In this case will be a nursing home or an assisted living unit. And then we have here the bag of inappropriate pattern of activity. Repetitive, purposeless behavior. And there is a variation. Some of them going back to the nurse station, some of them going back to a person that they target, and suddenly this person feels disturbed by them. Sometimes those repetitive behavior is because they collect objects. I have patients, I go to the dining room and I pay attention. They leave the tray after eating and they collect all of the sugar. They collect all of the little containers with cream. They collect a few fork and knife and have a little package, put it in their pocket and go. And I said to the social worker and my nurses working with me. Where do you think this go? And well, one day one of the nurses laughed and said, come over here, I will show you where it go. We go to the room of the patient. We open the second drawer on the and there was full, but I mean nice amount of sugar, cream, all the things, all. And some food, this I think it put there probably 3 or 4 weeks before because where everything dry. And therefore, these are inappropriate partner of activity. In general, they struggle very much with how to place and how to dress, how to place a clothes and how to dress appropriately. They have difficulties with buttoning and unbuttoning. I already alert you. This is the apraxia. The apraxia doesn't let them. That's the reason that we always recommend to use Velcro. And in general, then Velcro is so easy to open it, and they go and undress themselves on the dining room, use Velcro on the back. What you don't see, you don't act in what you don't see. Therefore, those are some of the accommodation that you can do. And there is a deviation from socially prescribed conduct. Some of them so benign, because I received a telephone call from the nursing home. Hey, Dr. Praderio, we have a case of inappropriate sexual behavior. Inappropriate sexual behavior. Can you tell me a little? Well, John Doe left the lunch and then he took the hand of Mary Doe, and we found them walking on the hallway, hands on hand. And I said, but this is not sexually inappropriate behavior. That is to demented individuals that they don't know any longer who they are. And they are just comforting each other by hugging each other by the hand. And probably imagining that they are a couple. That is John Doe, possible wife, and is married to possible husband. Therefore, we need to see it, we need to eat. There are other cases in which one inappropriate sexual behavior occurs. But this deviation from socially prescribed conduct, you need to pay attention what is the manual of conduct that you have, because sometimes you need to superpose over the rule what are the defects of the brain and how to work. And appear that most of these behavior are associated with involvement of the cortex nucleus in the frontothalamic areas of the brain. And it's difficult to treat, it's more easy to understand. Well, here is reigning depression. Because from the first initial stage to almost the last part of the moderate stage, depression takes place. And look at the prevalence. It's so wide in the range that it's impossible to say that almost the majority of the patients are going to become depressed with the diagnosis of Alzheimer's disease. I don't want to be super fine academic today to tell you, be sure that you differentiate what is a depression that occurs after the diagnosis of Alzheimer's disease and what is a depression that is coming since you were 40 years old and then you become demented. We need to differentiate, but you know what? We need to diagnose, and as soon as we diagnose, we need to treat it. It's associated with an increased motor activity, sometimes with decreased motor activity. they have difficulties with insomnia, many times become irritable and change their appetite, correlate very much with the decline of cognitive function. And in general, if depression occurs in the process of the disease, invite me as a treater to think that we maybe have a pre-morbid psychiatric history. Are you sure that your mother never have depression before, never have trauma before? Because we need always to explore if this is a late life depression or is something that's occurred before. A little in how behavior work with neurotransmitter. Neurotransmitter is the form of communication this neuron to neuron have on the brain. Acetylcholine is the neurotransmitter involved with dementia, with Alzheimer's disease, memory impairment, delirium, some delusion, and some form of agitation. Dopamine is involved with psychosis, Parkinson, depression, and abnormal movement. Noradrenaline with depression, lack of attention, anxiety, and fear, as well as serotonin, another one with depression, OCD, and worry. And glutamate is one of the latest studied neurotransmitter. This is involved in studies of neurotoxicity and self-damage. This is the neurotransmitter involved in the use of Namenda, memantine medication that we use for the treatment of individuals with Alzheimer's disease. Well, your family member, you sense, or the doctor of your father and mother sense, that maybe we are in the presence of some memory disturbance. It will be good to send it, well, let's go and send it to Praderio. I take into consideration in my process of diagnosis a physical examination and medical history. I like very much what I received from my colleague who saw the patient before. And then a personal interview with the patient as much as possible. And please, like a pediatric medicine, geriatric medicine, you need family or you need someone, caregiver, to give you social history, level of functioning, level of participation, in order to cohesively have some understanding of your case. And then we go into a mental status examination. And this is the test who give us the better idea where we are. A mini mental state examination, in which one is a test with questions. This is given by my nurse or one of my employees. And they have a score. This is giving you an idea at what level of the disorder, at what stage of the disorder we are. It's a minimum initial one, it's a moderate one, or it's an advanced one. Neurological examination is indicated. I request psychological testing in cases in which one we need more specificity. I request psychological testing when I have to go to court and testify in cases that are involving a will, in cases that are asking for a specific capacity of patient to participate or to sign documents. I do always brain scan, not necessarily EEG, and laboratory studies looking for the level of vitamin B12 thyroid functions, and other blood work. This will alert me if we are not missing something else. Briefly, for you to understand the stages, the disease have an initial or mild stage. This in general go to 2 to 3 years. An intermediate or moderate stage, this sometimes prolonged to 7 or 8 years, but this is the stage this more behavioral disturbance occur, and this is the stage where people end up in supervised environment. This is the stage where they go in the majority of the time to nursing home, assisted living unit, memory unit. In the advanced severe stage, patients are not recognizing any family member. They start walking in almost a fetus position. They are not connected to the environment any longer. They stop eating. They lose remarkable weight. A little brief, just refreshment for you. What is an initial stage? Start repeating. They repeat in a conversation on the phone with you. Maybe they will tell you the same thing every 10 minutes. Get lost easily. Lost interest in tasks they enjoy. Characteristic at this point, I like to ask questions because my mom doesn't like to read the newspaper anymore. My mom doesn't play on the game on the computer anymore. Why? Well, finally, the mom is the one who said to me, I don't know, later on, I don't know how to handle that. Because I get very confused and I say, well, I just go and I eat something and that's it. Difficulties in finding names. Sometimes they show up with a little piece of paper with a telephone number and they leave it on the counter, and then someone comes and says, Daddy or Mom or here, what is this telephone number? Wow, they give it to me today. And I say, well, I need to write it down. I need to write it down, not to forget. But you forgot the name of the person who gave it to you. Well, I cannot be perfect. And this start occurring. Lose think frequently. There are some personality change. They get a little more defensive and depressed. On the moderate stage, it's more confusion. It start having difficulty dressing. And here we go. False belief or belief think are real when they are not. And start delusions and hallucination. And I told you, start boiling and boiling, require more supervision, hyperactivity, agitation and irritability, end up nursing home or assisted living unit. In an advanced severe stages, they cannot do think on their own anymore. They cannot understand commanding word. Therefore, they cannot recognize the person in the mirror. They don't recognize themselves, and they take an object and try to destroy the mirror because someone is looking at them. Therefore, this is a recommendation. If you are having your loved one at home, be sure that you don't have mirrors around. But those are the ones. How we manage this? We have treatment with medication. We call them pharmacologic treatments. We have behavioral interventions in which one we learn in trying to accommodate the situation. We have family support and education. This we have our group of support. We can talk about face-to-face. In my case, if I am going to celebrate 30 years in Corpus Christi, face-to-face will celebrate 2 months later, 28 years in Corpus Christi. Therefore, we have a support group that have 28 years of life. And you know what? We are very proud because some people say it's very difficult to maintain a support group. Thanks God, we have been successful in a good integration of modalities. We need, from the beginning, to have a good communication with the primary care physician, back and forward, because if I change medication, I want you knowing why. If you change medication or see something, this is not working well, just give me a call. A frequent review of the plan of care with caregiver, with family, or with professional caregiver. I mean, we need to be honest, because if the plan of care is all patched up, but we feel like it's not working, let's go sit. Maybe we need to do some change. Seek and share information about what resources are. I use my time in here with the caregivers and the family, giving some recommendation, but I can not spend an hour and a half with each one of them because I have 10 waiting behind. Therefore, I connect with some community resources. This is where Caregiver SOS appear on the picture. And other agencies on the community that offer support and some indications and recommendations. I always alert from day number one where we are in the counseling for legal and financial issues as is needed. It's for me an obligation to sit in front of my patient and to know in 1 hour, hour and a half of intervention, if he is going to be protected from the inherence of other things in life. I cannot leave him driving and I believe that he is going to crash his car. I cannot live without power of attorney if he doesn't have the idea of what is going on around. Therefore, this counseling for legal and financial issues and support the group invitation is very important. Mm-hmm. Well, Evelyn, I think we are going to conclude and we will have some time for questions. We have to get ready, get you very ready with a question. What is important in conclusion is early diagnosis and treatment is important. And I sometimes have sarcastic colleagues of mine telling me, Nestor, how important is early diagnosis if you don't have cure? Well, in certain form, very pragmatic and concrete, it's an excellent response. But on the other, early diagnosis and treatment allow you to prepare with a little more time what maintenance treatment you are going to do and how many other people you need to educate to make this process smooth. Target cognitive and non-cognitive deficit is very important. This is not just shaking medication and here you have. Remember how rehabilitation works in life. Someone fractured my arm and they put in a cast, and 3 months later, they removed the cast and I go to rehab. And every day I get better and better and better. And one day my left arm looked even better than my right. And here I am, I finished with my fracture. Well, dementia take our brain. And the amyloid deposit over the neurons like you are splashing cement in a wall. You are throwing pieces of cement, liquid cement on the wall. And thus, you cannot grab and send to rehabilitation. But what you do in non-cognitive approaches is you utilize the part that says, okay, and you're trying to multiply it. You take advantage of what is working. You enhance what is working. That's the reason this I always say, don't take away actions from there. If they want to eat with a fork, regardless that they just spell something in here, accommodate something for the spelling, but leave the fork because it's enhancing what is working. We need to balance supervision with meaningful activity. To restrain someone doesn't mean meaningful activity. I know that they may take the coffee and spell it. Well, buy one of those cups. This is difficult to spell. Educate, counseling, advice regarding treatment, intervention, and have a lot of hopes. These things are going to work okay, and this little by little, we have to share. Each one of us have a little oasis of information and knowledge that we can share. We cannot be selfish about this. Well, here we are, Evelyn. I am waiting for a lot of questions. I don't know why. It's a little cold today and people will just want to ask questions.
Well, I hope we have a lot of questions, and I am just so impressed. This is like the clearest presentation I've ever heard on behavioral disturbances and with dementia. And many people have tried. I know. So please, folks, if you're on the phone, press *6. And I have a little website and I can see that you've done that. If you're on Zoom, you can put something in the chat room, or you can unmute yourself, or you can put your hand up and I will see that. But we would love for you to join us and to, really help us make this even more robust with your questions. Anybody? Well, Dr. Praderio, I have to tell you, I've taken a lot of notes here. And one of the things that I was that was new to me was the whole thing about the neurotransmitters and the role that they play. Okay, wait, Ali Simpson has her hand up. Thank you, Minerva. Ali?
Hello. I wanted to ask you about the repetitive behaviors. My grandmother had some of those behaviors where she collected creamers and sugar, sometimes even the salt and pepper containers. And I attested it to being part of the depression where there was just a mindset of lack and not enough. Would you relate those repetitive behaviors to that, or is that more because of the dementia? Would we see in different generations different repetitive behaviors, or would you say the same behaviors?
Wow, what a question. It's a loaded question. Excellent question. Let me start telling you this. I don't believe this. I have a specific answer for your interested content of question. But there is no doubt, the generations carry with them and with the change a different approach on the response and the type of symptoms that are going to occur. Specifically, some of my elderlies and impatients have an expression that the only thing that they can do is to play bingo. And my other patient and impatient wait for me out the outside of the room and say, "Doctor, I cannot stay in here any longer. because I don't have any interest to play a stupid bingo. And I say, what do you want to play? When I want to play, if I can bring my box, my 360 box, and hook it up to this television, I will be happy playing my games. Therefore, Ali, the generations are marking in certain form the habit of the individual and the reproduction into behavioral disturbance. Now, we will have to do more for culture, for gender, for not knowing the response to all of those. But in general, at the level of functionality of the brain, they are all similar. I think this dementia for HIV are more depressed and more agitated. And there are surrounded by sadness and almost a disillusion of life, different than some of the happiness that you see in Alzheimer's disease, laughing and having a good time, regardless how much they understand. Therefore, there are some suggestive change, but in general, the agitation, the repetition, the OCD, the obsessive compulsive behavior are very similar between one and another.
Thank you.
Thank you.
Thank you, Doctor. We have a question from Donna. How different are the symptoms with other dementias? Are the stages and symptoms the same for FTD and vascular dementia?
Well, very good question, Donna. No. In general, some of the dementia characterized for some specific symptom. Therefore, we have dementias with a battle line of similar symptoms, and some of them have a specific. For example, frontotemporal dementia have a point of beginning or an onset of illness. This is, in general, early than Alzheimer's disease. Frontotemporal dementia have a better recollection of memory, but have more agitated behavior. Frontotemporal have hyperphagia. Hyperphagia does mean they need to eat constantly. They eat the plants on the nursing home. They eat anything that's go around. Frontotemporal dementia have an encoding that is better than Alzheimer's dementia. Therefore, I have two dementias in this room, and I have a locked door with a code. The frontotemporal dementia will remember the code number and escape. The Alzheimer never will know the code number. Therefore, yes, there are some difference, and we try, similar with Lewy body dementia, we try to be aware of them in order to work more appropriately with the patient.
Wow, that was great. Okay, folks, we have time for one more question, and then we have an announcement.
What does executive variant dementia mean? Well, there is no such a, well, might be in some work that they use the term executive variant, but in general, any dementia have problems with executive function. This is the frontal prefrontal center, in which one we have the specific information, we have the center collective of our life, and those executive functions start deteriorating. Therefore, we start failing in calculation, in decision-making decision, in judgment decision, in memories that structurize our life, in memories that were not attending to us. For example, you can become demented, but if your executive function is still partially intact, I will give you two examples where a demented male urinate if he have wishes to urinate in a nursing home? Well, he will go to the near closet, regardless if it's full of clothes or not. We'll open the door, get in, and urinate there in a standing position. And you will say, Joe, please come over here. Where a female patient will urinate in a nursing home? Well, in a paper basket. She will move it to the side of the bed. She will sit down and urinate there. Why? Because those were the memory implant of growing up through life. Your dressing and all of those things. But there is not a specific dementia that is purely associated with executive function.
Well, thank you for that, Dr. Praderio. I think we're out of time. I'm so sorry, because I know you could probably talk all day on this subject, and I would love to hear you do that. Let's see. Elsa Munoz has one quick question for us.
No, I have an announcement.
Oh, Elsa, that's you. I'm sorry.
Yes.
We have a very important two announcements here.
Okay. Yes, we'd just like to invite everyone to the 2023 Healthy Aging Forum that's going to be taking place on Wednesday, May 17th this year at the First United Methodist Church. It'll be a half-day event, 8 to noon. We'll have exhibitors, and we will have 3 sessions with Dr. Praderio presenting the keynote. So registration will be open soon. It'll be on Eventbrite, and you can also access it through our Facebook and website. You could also call early if you want to reserve starting whenever Marianne gets back to her office at 361-826-2343. That's 826-2343 to register by phone. Thank you.
Thank you so much. I want to let everybody know that I'm going to do some, just talk a little bit real fast about the sessions that we have coming up, because we've got some really good ones. And I want to just thank Dr. Praderio so much. I mean, this was a fabulous presentation, as always. Thank you, Elsa, for the announcements. For those of you who are on the line, in several days, you'll receive a post-session questionnaire, and I'm very sorry if the announcement for the program today was messed up.
I was getting tongue-tied. It was like, I forgot.
The post-session questionnaire will include any resources we've discussed today, unless you're not registered for the session. If you're not, you need to call our customer service. If you have an urgent question for Dr. Praderio, you can also call our customer service, and I'm sure we can forward that. The customer service is 866-390-6491, 866-390-6491 if you're not already registered. And then you'll get the monthly calendar in addition. I'd really like to thank Dr. Praderio, all of our participants. It was so much information, but very simply presented and really astounding. And I want to thank caregivers for what they do every single day. So some of the new sessions that we have, we've got Dr. Sklar and Lucy, our dear Lucy, tomorrow presenting on how to handle uncertainty. And then next Wednesday on how to process sadness. We also have several presentations coming up on suicide and aging, combating compassion fatigue, and a time to say goodbye to toxic people, and understanding grief and loss. So we have very many interesting things coming up. If you need a calendar, please call that number at our WellMed Charitable Foundation. And I'm going to stop the recording now and just thank you all so much for today. Thank you for those who joined in late. I'm sure Minerva was out there, pushing to get people on the phone. Thank you, Minerva. You're the best. Okay. Goodbye, everybody.